So picture this. You are sitting on the edge of an exam table in one of those, you know, flimsy paper
Oh,
gowns.
yeah, shivering a little bit.
Exactly, shivering. And a doctor hands you a clipboard. It's a stack of consent forms for a procedure or maybe like a summary of a new diagnosis.
Right.
And there is this heavy, unspoken expectation that you actually understand what you are signing.
Right, like you're supposed to just know.
Yeah. But as your eyes skim over words like salpingo-oophorectomy or metrorrhagia, you realize pretty quickly that the forms dictating the future of your own body are, well, they're secretly written in ancient Greek.
They literally are. And I mean, it is a profound vulnerability.
Yeah.
Medical terminology functions as this highly efficient shorthand for clinicians, but for the patient. It acts as a really effective gatekeeper.
It totally locks you out.
It does. It keeps you on the outside of your own healthcare.
Right.
Like, we crave clarity when it comes to our bodies, but this language is inherently opaque if you don't hold the key to the code.
Well, that is exactly what we are going to bypass today. We have a stack of linguistic, historical, and medical sources in front of us, and our mission for this deep dive is to hand you that key.
Love it.
We are going to decode 3 foundational roots of the female reproductive system. So that's gyneco, hystero, and metro.
The big three.
Big 3. But this isn't just a vocabulary lesson. We're going to look at how understanding these seemingly simple hidden codes fundamentally shifts the power dynamic in a doctor's office.
Because, I mean, these 3 tiny Greek roots do a lot more than just describe anatomy.
Right.
If you look at how they are used and how they have been misused over the centuries, they carry the weight of historical biases, massive medical misconceptions, and honestly, an ongoing struggle for bodily autonomy.
So the definitions are just the starting point.
Exactly. The real insight is in how these words actually dictate patient care.
Okay, so to uncover the secrets hidden in those medical charts, we first have to understand the architecture of the language itself.
Right, how it's built.
Yeah, because this isn't just a random assortment of syllables. I like to think of medical terminology almost like an open source coding language.
Well, that's a good way to look at it.
Yeah, you have your base functions, your syntax connectors, and your executing commands.
That is highly accurate, actually.
Yeah.
The base function in this code is the root word, which is usually pulled from Greek or Latin,
Right.
and that gives you the core anatomical meaning. Then you have a combining vowel, which is almost always the letter O.
Just the letter O.
Pretty much always O, yeah.
Yeah.
That O is the syntax connector. It just smooths out the pronunciation so you can link the root to another component.
Got it.
And finally, you attach a prefix or a suffix, which acts as the executing command, like you said. So the root tells you what part of the body is being discussed, and the suffix tells you what is happening to it.
Okay, so if we apply that to our first root, gyneco, how does that execute?
So gyneco is the broadest root in this entire system. It translates simply to woman or female. Because it does not describe a specific organ or a piece of tissue, it functions in the medical coding language as a massive subject heading.
So it's broad.
Very broad.
Damn.
Tells you whose body the term concerns, not what part.
Yeah.
So if you add the suffix -ology, meaning the study of, you get gynecology.
Which means a gynecologist isn't defined by a single organ system the way, say, a cardiologist is with the heart, but by the patient demographic itself.
Exactly.
So they might be managing endocrine function and hormones, or screening for cellular changes like cancer, or, treating bacterial infections, all under this one broad umbrella root.
You nailed it. It establishes the territory, but it doesn't give you the coordinates of the specific structures inside that territory.
Right.
To do that, you need roots that describe the actual anatomy. And that brings us to hystero and metro.
Okay.
Both of these roots translate to uterus.
Wait, really? Both of them?
Both of them, which, I mean, immediately feels like a flaw in our coding language, right? Like, why have 2 different base functions for the exact same organ?
Right. I would assume just logically it comes down to a difference in scope.
Exactly.
Like if hystero refers to the uterus as an organ, like the physical structural object itself, then you'd probably use that root when talking about the mechanics of a surgery, right?
Spot on. You will almost exclusively see hystero used in surgical or procedural terminology.
Okay.
If you take the suffix ectomy, which means surgical removal, and combine it with hystero, you get hysterectomy, the physical removal of the entire organ.
Right.
Or if you use cascopy, the process of viewing, you get hysteroscopy, where a lighted camera is physically inserted to view the inside of the structural cavity.
Okay, let's unpack this for a second. So if histero is like the structural framing of a building, then metro must refer to the specific materials inside it, which
Yeah.
would explain why conditions involving the inner lining of the uterus use the metro root instead.
That architectural visual actually works really well as a starting point.
Oh.
But clinically, we have to stretch it a little bit. Well, because unlike the drywall or insulation in a house, the metro layer is living, highly active tissue.
Oh, right, of course.
Metro refers specifically to the uterine tissues. So that's the muscular walls and the inner lining. This tissue is dynamic. It responds to hormonal signals. It thickens, it sheds, it contracts.
Right, so we use metro for pathology and tissue states.
Exactly.
Like if we take myo for muscle and combine it with metro, we get myometrium,
Yes.
which is that incredibly thick muscular wall that has to, contract forcefully enough to push a human being out into the world.
It's an incredibly powerful muscle.
Or taking endo for giving us endometrium, the inner cellular lining.
Precisely. And this distinction between structure and tissue is exactly why a symptom like irregular bleeding between menstrual periods is diagnosed as metrorrhagia.
Oh, okay.
You use mithro, not hystero, because the bleeding is a functional issue with the shedding of the tissue, not an issue with the organ as a solid surgical object.
That makes so much sense. But because this language operates so methodically, it creates these brilliant little traps for the patients reading it.
Oh, totally.
If you don't know the nuances of the code, it is incredibly easy to make massive, sometimes life-altering assumptions.
Very easily.
And looking at the sources, the biggest linguistic trap here is a false twin involving metro.
Yes, it trips people up constantly.
I bet.
So, as we established, metro comes from the ancient Greek word metra, meaning womb.
Right.
Interestingly, that is very closely tied to meter, the Greek word for mother.
Oh.
Yeah. But it has a visually identical twin derived from a completely unrelated Greek root, metron, which means to measure.
To measure. So words like thermometer,
Yeah.
like the metric system.
Right. The meter and the thermometer are measuring your fever, and the metro and the endometrium lining the uterus have absolutely zero etymological relationship.
None at all.
None. But once they were anglicized and formalized into modern medicine, they ended up spelled the exact same way. It is a total visual trap.
That is wild. And if the terminology itself is this fragmented and full of traps, it makes sense that the actual clinical specialties would split along those same linguistic fault lines.
Yes, they absolutely do.
Let's talk about obstetrics and gynecology.
Right.
We always say OBGYN like it is one single job title, which leads a lot of people to assume that gynecology covers pregnancy.
It is a very common misconception.
Right.
Obstetrics and gynecology are two entirely distinct medical disciplines with totally different historical origins.
Oh, okay.
Obstetrics derives from the Latin word obstetrix, meaning midwife.
Midwife, right.
Yeah, that entire field is dedicated to pregnancy, childbirth, and the immediate postpartum period.
Okay, so then what about gynecology?
Gynecology, heavily rooted in these Greek terms we were discussing, was formalized much later in the 19th century and is strictly dedicated to non-pregnancy-related anatomy and physiology.
So obstetrics is the event, and gynecology is the baseline anatomy. They
Yeah.
practice together today, hence the combined acronym, but conceptually they are completely separate.
Exactly. And clearing up these conceptual boundaries is crucial for a patient sitting in a surgeon's office.
Right, let's apply that directly to a surgical chart. We just defined a hysterectomy as the removal of the uterus. So hystero plus anectomy.
Right.
But the overwhelming cultural assumption is that a hysterectomy means, like, everything goes.
Yes.
Ovaries, fallopian tubes, the works. The assumption is that removing the uterus automatically triggers surgical menopause.
And that is a critical misconception we really need to dismantle.
Let's do it.
A standard hysterectomy removes only the uterus.
Right.
And usually the cervix. That is the full extent of that specific term.
Just the uterus.
Just the uterus. The ovaries are entirely separate organs, and they have their own completely different linguistic root, which is oophouro.
Oophouro. That's a mouthful. So removing them is an oophorectomy.
Correct. And the clinical mechanics of this matter immensely to your long-term health.
Why is that?
Because the ovaries produce the vast majority of your estrogen and progesterone. Many patients keep their ovaries during a hysterectomy specifically to maintain that hormone production.
Oh, to prevent menopause.
Exactly, to prevent the sudden onset of severe surgical menopause, which can really impact bone density, heart health, and even cognitive function.
Wow, okay.
Yeah, so if a surgeon intends to remove the ovaries as well, they cannot just write hysterectomy. they must explicitly document a bilateral salpingo-oophorectomy. Bilateral meaning both sides.
Right. And that distinction right there is exactly why understanding this code is the bedrock of informed consent.
Absolutely.
If you misread hystero as meaning the entire reproductive system, you might decline a necessary surgery out of a misplaced fear of losing your hormone production.
It happens.
But, while understanding hystero empowers patients today, the historical misunderstanding of that exact root caused profound damage for centuries.
It is arguably one of the most destructive linguistic legacies in medical history.
Here's where it gets really interesting, right?
Oh, definitely. To understand it, we have to look at how the ancient Greeks conceptualized the hystero root.
Okay.
So in classical texts, particularly the Hippocratic corpus from 5th and 4th centuries BCE, and later in the writings of Plato, we see the concept of the wandering womb.
The wandering womb. It sounds like an old folk tale, but they meant it quite literally, right?
Oh, very literally.
But what was the supposed mechanism for this? Why did they think an organ would just, decide to go for a walk?
Well, Plato actually described the uterus as a living creature within the woman, one that possessed an independent desire to bear children.
A living creature.
Yes. The prevailing medical theory was that if a woman remained celibate, or if the uterus became too dry, it would literally detach from its moorings and wander aimlessly through the abdominal cavity, searching for moisture.
That is just, wow.
They believed it could travel up to the diaphragm or the throat, compress the lungs, and basically block the airways.
And because of that bizarre mechanical theory, any unexplained symptom a woman experienced, like shortness of breath, fainting, anxiety, was attributed to this roaming organ.
Exactly.
Which brings us to the birth of the word hysteria.
Yes, the diagnosis of hysteria was born directly from the root hystera.
It's all connected.
The very name of the psychological condition asserted, as a medical fact, that the physical uterus was the cause.
Right.
And the umbrella of symptoms it covered was massive. It wasn't just physical complaints, it became a catch-all for behavioral deviations, irritability, depression, sexual desire, or even just too much intellectual ambition.
The logic there is incredibly insidious. I mean, if the medical consensus dictates that a woman's psychological distress is physically caused by her uterus, by her hystero, then the treatments are going to target her body.
Exactly.
Often in ways that completely strip away her autonomy. In the 19th century, this diagnosis was weaponized to enforce the famous rest cure, where women were confined to bed for weeks, forbidden from reading, writing, or socializing.
Right. Charlotte Perkins Gilman famously wrote The Yellow Wallpaper, based on her own harrowing experience with that exact treatment for so-called hysteria.
Such a powerful story.
And in even darker chapters, the diagnosis was used to justify institutionalization and early reproductive surgeries, removing healthy organs to cure psychological symptoms or societal nonconformity.
But what blows my mind is that this didn't end in the Victorian era. At the end of the 19th century, Sigmund Freud publishes studies on hysteria.
He does.
He shifts the entire medical framework, arguing that hysteria is a psychological condition caused by repressed trauma, not a wandering physical organ.
So the mechanical theory is dead, right?
Yeah.
But the word survives.
It does survive.
Yeah.
Even as psychiatry evolved into a discipline focused on the brain and the unconscious mind, they kept the 2,500-year-old uterine Lego brick firmly in place.
That is crazy.
Psychoanalysis still humored the concept symbolically, keeping the word alive in the clinical lexicon.
So how did we finally shake it? When did the medical community realize they had to untangle this ancient Greek organ from modern psychology? It did not happen until 1980.
Wait, 1980?
1980. That is the year the American Psychiatric Association published the DSM-3, the third edition of the Diagnostic and Statistical Manual of Mental Disorders.
Okay, so it took that long.
Yeah. There was a massive push in the 1970s to move psychiatry away from abstract Freudian theories and toward empirical symptom-based criteria.
Makes sense.
As they reorganized the manual based on observable data, they finally dropped hysteria as a diagnosis. The symptoms were redistributed into precise, scientifically grounded categories like conversion disorder and somatic symptom disorder.
But it took over 2 millennia to break that linguistic link.
Yes. Over 2 millennia.
It is a stark reminder that the words we use in medicine are never just neutral descriptors. They carry the weight of the era they were forged in.
Very true.
And while psychiatry was slowly wrestling with the legacy of hysteria, the surgical side of gynecology was becoming a formalized specialty in the 1800s. But that foundation was built on an incredibly dark ethical reality.
Yes. To understand the modern debates around gynecology, we have to look impartially at how its foundational surgical techniques were developed.
Right.
And that brings us to the historical record of J. Marion Sims, an American surgeon in the 19th century, who is frequently referred to in medical texts as the father of modern gynecology.
He is credited with two major contributions, right? Inventing the Sims speculum, which is a tool still used in a modified form today, and developing a surgical repair for a condition called a vesicovaginal fistula.
Correct.
Now, for those unfamiliar, what exactly is the physical mechanism of a fistula, and why was it such a focal point for early surgeons?
So, a vesicovaginal fistula is a catastrophic birth injury. During a prolonged, obstructed labor, the intense pressure of the baby's head against the mother's pelvis cuts off the blood supply to the surrounding tissues.
Ouch.
Right. The tissue dies, it becomes necrotic, and it sloughs away, leaving a literal hole or fistula between the bladder and the vagina, or sometimes the rectum and the vagina.
Which means the patient loses all control over their bodily waste.
Yeah.
It results in continuous, uncontrollable leaking.
Exactly. And in the 19th century, before modern sanitation, a fistula effectively ended a woman's participation in society.
Just totally isolated them.
Completely ostracized due to the smell and the constant infections. It was a devastating condition, which made a surgical cure a kind of holy grail for doctors at the time.
But the way Sims developed that cure is where the grave ethical reality of this history lies.
It is.
Our sources detail that in the 1840s in Alabama, Sims developed his fistula repair by operating repeatedly on enslaved black women.
Yes.
And he performed these surgeries without anesthesia.
The historical records, Sims's own notes, specifically named 3 of these enslaved women: Anarcha, Betsy, and Lucy.
Right.
Anarcha alone was subjected to approximately 30 distinct operations before the technique was perfected.
30 operations.
And the inescapable fact here is the total absence of consent.
Yeah.
Because they were legally classified as property, these women had zero autonomy over their own gynecoanatomy. They could not refuse the procedures.
Which is exactly why the medical community and historians have heavily reevaluated his legacy.
Yes.
It is a historical fact that following years of public advocacy emphasizing this lack of bodily autonomy, a statue of Sims was removed from New York's Central Park in 2018.
Right, that happened fairly recently.
It forces us to confront how the authority over a patient's body was established in this field to begin with.
And that underlying tension, who actually holds authority over the uterus and the medical decisions surrounding it, does not just disappear because the century changes.
No, it doesn't.
It echoes directly into contemporary debates about how aggressively we utilize major gynecological surgeries today.
Which connects perfectly to the modern data in our sources regarding hysterectomy rates. The United States has historically had one of the highest rates of hysterectomies among industrialized nations, with hundreds of thousands performed every year.
It has been a subject of intense debate among researchers and clinicians.
Why is that?
Well, the scrutiny primarily focuses on hysterectomies performed for benign, non-cancerous conditions, things like painful fibroids or extreme chronic bleeding.
Okay.
The question is whether major organ removal, so the Hyster procedure, is being overused when the issue is fundamentally a tissue problem, a Metr problem, that could be treated with less invasive means.
Okay, but I want to push back on that for a second.
Sure.
The sources bring up the Maine Women's Health Study from the 1990s, which tracked patients who underwent hysterectomies for these benign conditions.
Yes, a very famous study.
Right. And that study found that the vast majority of these patients reported a significantly improved quality of life afterward. If the patients are happy and their pain is gone, isn't that a clear win for the surgery? Why is it controversial?
It certainly looks like a win in a vacuum, and that study was heavily cited to defend the high rates of the procedure.
Okay.
But the controversy isn't about whether the surgery stops the bleeding. Removing the organ obviously stops the bleeding. The debate is about the threshold for intervention. Critics point out that subjective relief after a major surgery does not erase the objective risks of that surgery.
Like what kind of risks?
Potential nerve damage, pelvic floor prolapse, or just much longer recovery times. Today, we have sophisticated alternatives like uterine artery embolization, which cuts off the blood supply to fibroids to shrink them,
Oh.
or endometrial ablation, which specifically targets and destroys the Metr lining without removing the structural organ.
I see.
So the ongoing debate is about ensuring patients are genuinely offered this full spectrum of less invasive choices before consenting to a total removal.
It all comes back to having the knowledge to navigate those choices.
Always.
Which brings us to how patients today are actively reclaiming these ancient roots to advocate for their own tissue. Let's look at a condition where the Metr root is front and center, endometriosis.
Yes. If we break this down using our medical syntax, Endo means within. Metro is the uterine tissue. And osis denotes an abnormal condition.
So an abnormal condition of the inner uterine tissue. But what is mechanically happening inside the body to cause the severe pain associated with this disease?
Well, in a healthy system, the endometrial tissue lines the inside of the uterus, thickens over the month, and then sheds and exits the body during menstruation.
Right.
In a patient with endometriosis, tissue that is remarkably similar to that lining grows outside the uterus.
That's high.
Yes, it attaches to the ovaries, the fallopian tubes, the outer walls of the pelvic cavity, and sometimes even the bowels.
But because it is endometrial-like tissue, it still responds to the body's hormonal cycles, doesn't it?
Precisely. As estrogen levels rise and fall, this misplaced tissue thickens, breaks down, and bleeds, just like the lining inside the uterus.
Oh, man.
But because this bleeding is occurring in the closed environment of the abdominal cavity, the blood has nowhere to go. It becomes trapped.
So it just sits there.
Yeah, and this causes severe localized inflammation. Over time, that inflammation leads to the formation of adhesions, which are thick bands of sticky scar tissue that can actually bind internal organs together.
Wow, that sounds agonizing.
It causes immense chronic pain and often leads to infertility.
And the scale of this condition is staggering. The World Health Organization estimates it impacts roughly 10% of women and girls of reproductive age globally.
That's huge.
We are talking about an estimated 190 million people. But traditionally, the medical system has been incredibly slow to diagnose it.
Historically, the average delay from the onset of symptoms to an accurate diagnosis of endometriosis has been between 7 and 10 years.
7 to 10 years? That is unacceptable.
It really is. And you can draw a direct line from that delay back to the lingering biases we discussed earlier.
Oh, like the hysteria stuff.
Exactly. The long history of dismissing severe pelvic pain or attributing it to anxiety or hysteria meant that patients' symptoms were frequently minimized.
But that is exactly where understanding this vocabulary becomes a weapon for the patient.
It really does.
The modern endometriosis awareness movement is heavily utilizing this precise metro terminology. By understanding the mechanics of the tissue, that it is not just bad cramps, but a systemic inflammatory disease acting outside the organ, patients are refusing to be dismissed.
They are. They are using the exact language of their own charts to demand faster imaging, specialist referrals, and targeted treatments.
That is so empowering.
When you understand the root words, the medical chart stops being a wall of intimidating Greek syllables and transforms into a highly specific map of your own body.
I love that visual.
And it extends beyond the three we've focused on today. You have cervico for the cervix, which translates to the neck of the uterus.
Right.
You have colpo and vagino for the vaginal canal. You have salpingo for the fallopian tubes.
Oh, I love that one. Salpingo comes from the ancient Greek word for a trumpet, right? Describing the flared shape of the tube where it meets the ovary.
Yeah, it is incredibly descriptive once you know what to look for. So when a physician recommends a procedure, you aren't just nodding along blindly. You understand the architecture. You can distinguish the structure from the tissue, the organ from the system, and you can make decisions rooted in absolute clarity.
So to bring it all back to that clipboard in the waiting room, we have decoded the core operating system.
We have.
Gyneco is your broad demographic subject heading. Hystero defines the surgical hardware, the physical structure of the uterus itself, and Metro zeroes in on the software, the living, changing tissue that lines those walls.
Knowing the difference isn't just, a party trick or a way to pass a biology exam.
Right.
It is the absolute prerequisite for informed consent. It exposes the historical biases that are baked into the very language of healthcare.
It really does.
And it ensures that when decisions are made about your body, you are an active participant in the conversation, not a bystander.
It is completely about taking the power back from the paperwork. We just saw how a 2,500-year-old mythological theory about a wandering womb managed to hide in plain sight in the psychiatric dictionary until 1980, shaping patient care for centuries simply because of the letters used to spell it.
It's pretty wild to think about.
So I want to leave you with a final thought to mull over. What other everyday words that we use right now to describe our health, our mental states, or our bodies might be secretly carrying the ghosts of ancient, discredited science hidden right there in their spelling?
That is a fascinating question.
Keep questioning the code, and we will catch you on the next deep dive.